Welcome back, everybody, to Medical Biochemical Genetics Clinical Course Seminar Series. It is December 3rd, 2021. It's week 19 of the series. We've only got 2 lectures left after this, and this week we're happy to have Reed Sutton come back and talk to us about neurometabolic conditions. It's the second part of his last lecture. So before I let Reed get started, I do want to have just a little discussion about housekeeping things, specifically about the test for the MBG Fellows. The test is being put together now. It will be sent out after the last lecture on the 17th. It should have close to 100 questions. It's going to be open book and honors roll for not sharing answers with other people. I should have grades out by beginning of January 2020. So you'll have about a week to complete the test, and I'll have about a week and a half to grade it over the holidays. If anybody is interested, or if the MBG Fellows are interested, please send Holly contact information, both for you and for your program director, including emails for both. And I think we may actually open this up too to CBG Fellows. So if you're a CBG Fellow and you're interested, please also feel free to send Holly your information. So that is all I have to say. Reed, without further ado, take it away. Thank you.
Okay, so it seems like everybody can see my slides, I guess. Is that right? Okay, thanks, Pete. I see you nodding. Okay, so we're gonna try to do the poll everywhere thing again today. I know there's a way to incorporate it into my PowerPoint. Figure it out this morning, and honestly didn't spend a lot of time. So I apologize. I'm gonna be going back and forth like I did the last time. But so this is the poll everywhere. It's the same one for the last time. So my first name, Vernon, V-E-R-N-O-N, middle name, Reed, R-E-I-D, and then SU 161. So if you just text that to 22333, you can, on your cell phone, you can participate when we get to the poll everywhere. And I would encourage you to participate. So hopefully it'll help you to remember things, because we'll have a couple of questions as we go through again to try to reinforce things that we're talking about. So as Pete had mentioned, so a few weeks ago, I had talked about creatine disorders, purine and pyrimidine disorders as part of the neurometabolic cluster of disorders. And today, I'm going to be talking about some neurotransmitter disorders, particularly disorders of dopamine, serotonin, and GABA, as well as succinic semialdehyde dehydrogenase deficiency. We'll talk about the 4 known serine deficiency disorders, including 3 enzyme deficiencies and a transporter, and then the vitamin disorders of riboflavin, folate, transport, and pyridoxine that, again, mainly are going to have neurologic phenotypes. So the objectives today are, hopefully by the end of the talk, you should be able to list phenotypes and identify biochemical profiles of disorders of neurotransmitter biosynthesis and recycling, be able to describe approaches to therapies for neurotransmitter disorders, describe the roles of serine in neurons, and you'll see there are quite a number of them, as well as the consequences of serine deficiency and potential therapies and biomarkers to assess therapies. And then finally, identifying signs, symptoms, and laboratory profiles for disorders of flavin coenzyme, pyridoxine, and folate transport, sorry. So just to start with the neurotransmitter disorders. So aromatic amino acid decarboxylase deficiency. The clinical presentation has a very wide range, anywhere from the first few months of life all the way into adulthood. It's characterized by low muscle tone, particularly in the early onset cases, rigidity, oculogyrate crises. You'll see that this, along with GTP, this feature is seen somewhat uniquely here, also seen in GTP cyclohydrolase deficiency. But again, this is a fairly unique phenotype. And so when you see something with someone who's diagnosed with an ocular gyrate crisis, you should really think again about this disorders of dopamine biosynthesis, such as AADC. They can also present with epileptic encephalopathy. Again, that tends to be the earlier onset cases, dystonia, and kind of along with the rigidity, obviously, kind of similarities to Parkinson disease, particularly again in the late onset cases. They can also have autonomic dysfunction, and you can measure homovanillate and 5-hydroxyindole acetate in the CSF, and these generally are low, and you'll see the pathway on the next slide. This disorder generally has a relatively poor prognosis, although the milder forms of AADC, the later onset forms, may have some response to treatment with MAO inhibitor, vitamin B6, or L-DOPA. So this is just showing the pathway here. So tyrosine gets converted to L-DOPA by tyrosine hydroxylase tryptophan, by tryptophan hydroxylase to 5-hydroxytryptophan. The enzyme aromatic amino acid decarboxylase, shown as AADC in green there, catalyzes the conversion from L-DOPA to dopamine, as well as the conversion of 5-hydroxytryptophan to serotonin. And then the subsequent products of dopamine are vanillamindelic acid, homovanillic acid, and then for serotonin, 5-hydroxyindole acetic acid. So that's why that's kind of one method for measuring CSF levels of these neurotransmitters in the diagnosis. And I'll show you another way as well that relates to this interconversion that you see between dopamine and 3-methoxytyrosine here. So we've now analyzed a few patients using our metabolomic analysis. And certainly, again, this is kind of showing you a profile. The affected patient is in the red circle, and then the box and whisker is the mean and 2 standard deviations from the mean. And then the open circles are unaffected individuals. So you can see individual with AADC has very high levels of 3-methoxytyrosine, also known as 3-O-methyl-DOPA, shown here, about 6 standard deviations above the mean, and then low levels of dopamine and VMA, again, as you would expect based upon that pathway. Another enzyme in this neurotransmitter biosynthesis pathway is tyrosine hydroxylase that I'd mentioned earlier, which converts tyrosine to L-DOPA. This presents with hypokinetic rigid syndrome. They also have dystonia, can have encephalopathy and developmental delay. Occasionally, they have seizures, although not as frequently as with AADC. They can have tremor and chorea. And similarly, these individuals have low levels of HVA because tryptophan hydroxylase is not impaired. The 5-hydroxyindole acetic acid should be normal. And so another helpful assessment is to do a ratio of the homovanillate to 5-hydroxyindole acetate, because again, the HVA should be not only low, but particularly low in comparison to 5-hydroxyindole acetate. This, again, as with AADC, has a relatively poor prognosis, and in general, most individuals do not get much of a response from L-DOPA therapy. GTP cyclohydrolase deficiency also has been called DOPA responsive dystonia. The onset of this is typically in childhood, usually right about school age, and it often presents first with lower limb dystonia. If left untreated, this will go on to progress to a more generalized dystonia, And again, as with AADC and tyrosine hydroxylase, rigidity, bradykinesia, and other kind of Parkinson, sorry, I misspelled that. It looks like Parkinson-like features are seen. Also, again, as I'd mentioned, as with AADC deficiency, oculogyrate crises are pretty common. And so again, the importance of noting that. Somewhat uniquely for GTP cyclohydrolase deficiency is that they generally have a diurnal fluctuation when they are better after sleep as compared with kind of toward the end of the day being up. If treatment is not initiated fairly soon in the course of the disease, they will go on to develop intellectual disability. This is the first step in the synthesis of tetrahydrobiopterin. And so what you see is decreased levels in the CSF of both biopterin and neopterin. And in contrast, again, to AADC and tyrosine hydroxylase, they generally respond pretty well to L-DOPA. Other monoamine disorders to cover just for completeness. This first one, dopamine beta hydroxylase deficiency, presents with orthostatic hypotension, poor sympathetic function, and generally they have no cognitive impairment. It's due to the inability to convert dopamine to norepinephrine. And so they have low levels of plasma epinephrine and norepinephrine. And the treatment for this is with dihydroxyphenylserine. And then there's monoamine inoxidase. That's an X-linked disorder. It's associated with mild intellectual disability, aggressive behavior, and this is a defect in the catabolism of serotonin. So they have increased or relatively increased levels of vanillamindolate, homovanillate, and 5-hydroxyindole and 3-O-methyl-dopa, and there's no known treatment for monoamine oxidase deficiency. GABA transaminase deficiency presents with epileptic encephalopathy. Some have myoclonus, some have chorioathetosis. On brain MRI, you see decreased myelinization, shown in the images on the right, lower panels, as well as hyperintensities of the deep brain, particularly shown in the second panel and some in the third panel there as well. They have increased CSF and plasma GABA levels, and presently there's no known treatment. We've published that, again, by untargeted metabolomic analysis in plasma, we have been able to identify individuals with GABA transaminase deficiency without the need to measure CSF directly. And this is based upon, you see here the pathway here, the red X next to the green GABA transaminase enzyme shows the block in this disorder. This leads to a buildup of GABA and low levels of succinic semialdehyde and succinate. And GABA is interconverted non-enzymatically to a compound called 2-pyrrolidinone, which we're able to measure in untargeted metabolomic assay. And again, over on the right-hand panel, you see two individuals with GABA transaminase with very high levels of this 2-pyrrolidinone compared to the normal range or unaffected individuals, again, in the closed white circles there. And then the next step after GABA transaminase is succinic semialdehyde dehydrogenase, shown here. This disorder presents with low muscle tone, developmental delay, seizures, ataxia, abnormal brain myelination. As with GABA transaminase, you can have deep brain hyperintensities. You also can have cerebellar atrophy. And again, these individuals have increased GABA and gamma hydroxy isobutyrate, and there's no known treatment presently for succinic semialdehyde dehydrogenase deficiency. So in summary, for this section of the talk, so GABA-related disorders are non-specific epileptic encephalopathies, and again include GABA transaminase and succinic semialdehyde dehydrogenase. DOPA-related disorders often present with dystonia and rigidity, and particularly within these disorders, aromatic amino acid decarboxylase and GTP cyclohydrolase deficiency are characterized by oculogyric crises, which is a fairly unique phenotype, and so should always prompt you to think about these dopamine biosynthetic disorders. And also notably for GTP cyclohydrolase, this does have a diurnal variation pattern. Early diagnosis and treatment for GTP cyclohydrolase can prevent further symptom development. And in general, for most of these disorders, there's not a lot that you're going to see on kind of general testing. There is at least one study that's looked at urine levels of VMA and HVA and identified low levels, again, in aromatic amino acid decarboxylase deficiency. We've looked at our urine organic acid lab database of known cases of, that we have diagnosed with AADC deficiency, and unfortunately, we've not seen that we see really kind of significantly abnormal levels, elevated levels of these things that would allow for the diagnosis of AADC deficiency. So I'm going to move on to do a couple of poll everywhere questions. Okay, so here's a question. So oculogyric crises are typical of which neurometabolic, oops, sorry for the misspelling, disorder? So AADC deficiency, cerebral folate deficiency, GABA transaminase deficiency, or phosphoserine phosphatase. And again, the text to 22333, you can text, you see at the top of the slide, hopefully Vernon Reed SU 161, and then you should receive a text back saying that you've joined, and you can enter A, B, C, or D. Okay. Here's the next question. Diurnal variation in symptoms is most typical of which disorder? AADC, GABA transaminase, GTP cyclohydrolase, and succinic semialdehyde dehydrogenase. Okay, looks like everybody's doing great so far. And then elevated levels of plasma 2 pyrrolidinone are typical of which disorder? AADC, GABA transaminase, hereditary folate malabsorption, pyridoxine-dependent seizures, or succinic semialdehyde dehydrogenase. Okay. Okay. Let me go back to my presentation. We're going to move on to serine deficiency disorders. So in the serine deficiency disorders, we're going to be discussing phosphoglycerate dehydrogenase, phosphoserine aminotransferase, and phosphoserine phosphatase deficiency, as well as deficiency of the serine transporter. Serine biosynthesis disorders, again, result from deficiency of the 3 enzymes I just mentioned that leads to systemic deficiency of serine. This can present with a very broad phenotypic spectrum, and all three of these disorders are inherited in an autosomal recessive pattern. As with a number of the neurotransmitter disorders that we just discussed, there's a wide range of severity, anything from lethality in infancy with multiple congenital anomalies to a mild childhood form, which primarily presents with intellectual disability. And then again, kind of a range in there in between, including mainly neurologic phenotypes and poor growth. So serine can come from one of a couple of sources. So certainly shown in the bottom right from either kind of diet, endogenous protein or phospholipid turnover, and from interconversion of glycine, we can generate serine. But you'll see particularly in neurons that because serine has a limited availability to get into the CSF and neurons, we have this de novo biosynthetic pathway for serine, where glucose is first through a series of steps converted to 3-phosphoglycerate. And then again, the phosphoglycerate dehydrogenase converts that to 3-phosphohydroxypyruvate. Phosphoserine aminotransferase converts 3-phosphohydroxypyruvate to O-phospho-L-serine. And then the final step, phosphoserine phosphatase, converts the O-phospho-L-serine to serine. So what is serine doing in the CNS? Sorry, I forgot it was not in view mode. So again, as I mentioned, the CSF is not super permeable to serine, and so a lot of this is coming from glucose crossing the blood-brain barrier, shown over on the far left-hand slide. And again, this pathway of generation of L-serine in the astrocyte. L-serine can then be converted to D-serine and can be exocytosed into the synaptic space, where it can serve as a neurotransmitter, particularly for the encouraging the release of glutamate from the presynaptic neuron. Shown over on the right, serine is converted in the brain to a number of compounds. So it's primarily used in the synthesis of various sphingomyelins through sphingonine and ceramide. It also is used to synthesize phosphatidyl serine. We looked at D-serine just a moment ago. That is again neurotransmitter. It can be interconverted to glycine, as I had mentioned earlier, and then for generation of pyruvate, ammonia, and water. So you can also have a disorder of serine transport. There is a specific serine transporter on the astrocyte, as well as postsynaptic neurons, that allows for transfer of serine from the astrocyte, where it is synthesized again into the postsynaptic neuron, as shown here. Mature neurons lack phosphoglycerate dehydrogenase, and so they are unable to synthesize serine themselves. And again, as I mentioned earlier, also the blood-brain barrier is poorly permeable to serine. So again, this transporter to get serine from the astrocytes to mature neurons is needed, as they are dependent upon the astroglial cells for their supply of serine. And again, this disorder shows a similar phenotype as noted earlier with that. So as I mentioned earlier, the kind of severe form presents at birth with multiple congenital anomalies, and this is called New-Laxova syndrome. Presents with things like intrauterine growth retardation, microcephaly, dysmorphic facial features, severe low muscle tone. They can have structural brain malformations, such as agenesis of the corpus callosum and lissencephaly, limb defects, ichthyosis, and other congenital anomalies such as cardiovascular malformations, renal agenesis, microphthalmia, spina bifida, cleft lip and palate, or all can be seen in Neulac-Sova syndrome. The infantile presentation is also intrauterine growth retardation and microcephaly, but they tend not to have the dysmorphic features or the major congenital anomalies that you see with Neulac-Sova syndrome. And then again, the childhood onset serine disorders, as well as the serine transport disorders, generally present primarily with neurologic phenotypes like seizures, developmental delay, ataxia, low muscle tone, and so on. So biochemical, this is just a summary of the both the kind of phenotypic and biochemical features of the different levels of severity. So in Neulac-Sova syndrome, again, this is generally lethal at birth. I wasn't able to locate anybody publishing levels, but in infantile serine biosynthesis defects, as well as childhood, you see that serine levels in the plasma are relatively low, although they're particularly for the later onset forms, there is some overlap with the general population normal reference range. Plasma glycine level is generally normal in these later onset forms, although can be low in the CSF in the infantile forms. But again, glycine in the CSF typically normal in the later onset forms. And then again, most notably, the CSF serine level is going to be your best diagnostic tool, as you can see in both the infantile and the childhood forms. This is generally clearly well below the normal range. The therapy is either with serine or serine plus glycine, and that has been purported to improve things like seizures, spasticity, school performance, and behavior. So just a clinical case presentation, a 1.5-year-old male with intrauterine growth retardation, microcephaly, global developmental delay, ichthyosis, and anemia. Had exome sequencing and was found to have a homozygous variant in phosphoglycerate dehydrogenase. Both parents were carriers. You can see the biochemical testing here. Plasma and serine glycine levels were low, as were CSF and glycine and serine levels. We've also looked again at metabolomics in 4 individuals with serine deficiency disorders, 2 with phosphoglycerate dehydrogenase and 2 with phosphoserine aminotransferase. Serine was low in all 4, so that's shown over on the right. The colored circles are the 4 individuals with serine deficiency disorders. The first at the very top is serine, followed by glycine, and you can see serine is quite low in all of these. Glycine is generally low as well in the plasma. Notably, what we also found is there were a number of glycerophosphocholine and glycerophosphoethanolamines that were also relatively low, at least in a couple of particular individuals. And we also saw that a variety of sphingomyelins tended to be low compared to the general population. And so we also were able to look in collaboration with Ayman El-Hattab at these 4 individuals kind of before and after treatment in their plasma. So you see over on the left, the star plots where the various circles represent different, in the first column, glycerophosphocholines, the middle column, glycerophosphoethanolamines, and in the final column, sphingomyelins. Black or dots represent biochemicals that are in the normal range. Blue ones are low, red ones are high, and the volume of the circle is relative to the z-score or the standard deviation before the mean. So again, for each of these disorders, we have the baseline level and then the levels post-serine treatment. And you can see, particularly in individuals 1 and 2, and to a lesser degree, individuals 3 and 4, you see that they had a number of glycerophosphocholine, glycerophosphoethanolamines, and sphingomyelins that were well below the normal range pre-treatment, and then that show improvement in the second panel for each of these after treatment with serine. So again, demonstrating kind of what was known about the importance of serine in the synthesis of sphingomyelins. Subsequently, Hilary Vernon and Carlos Ferreira also demonstrated similarly that elevated alanine and low serine winds up perturbing ratios of various sphingolipids in serine disorders. So to summarize the serine disorders, so serine synthesis and transport disorders cause primarily neurologic phenotypes, although the very severe end of the spectrum can cause multiple congenital anomalies in New-Laxova syndrome. CSF serine levels are generally the optimal diagnostic test, although most individuals will generally have low plasma serine levels as well. Treatment with L-serine may prevent or ameliorate certain symptoms, particularly seizures and developmental symptoms if started before significant neurologic injury has occurred. And I've shown you that kind of metabolomics could be a possible tool for assessing or understanding responses to therapies in these disorders. And again, the pathophysiology, I think, at least in part, we would expect is related to perturbation of sphingolipid biosynthesis. Okay. So which category of biochemicals may be predictive of treatment response in serine disorders? Glycerophosphocholine, N-acetylated amino acids, polyamines, or purines? Okay, very good. Okay, I think hopefully everybody's back with me for vitamin disorders. So we're going to be talking about riboflavin, vitamin B2, pyridoxine, vitamin B6, and folate, vitamin B9. So we'll start with the case presentation on this one, a 25-month-old male who initially presented at 23 months of age with a possible seizure, but EEG was normal. At 24 months of age was noted to have pallor and a heart murmur, and CBC revealed anemia and neutropenia, and actually wound up receiving 4 transfusions. Family history was notable for a paternal grandfather with colorectal cancer and lymphoma, and the family was of mixed European and Native American ancestry and were not known to be consanguineous. He had a series of evaluations. Again, parents had reported developmental regression with refusal to walk and decreased use of words. After a 3-day history of fever, he developed cough and breathing difficulty and was found to have RSV. He had on exam ataxia, nystagmus, and brain MRI revealed just in sinus disease. CT revealed diffuse sinus disease, and brain MRI revealed diffuse T2 signal abnormality of the cord and the spine. Differential diagnosis at that point was some inherited bone marrow failure syndrome, such as Diamond-Blackfan anemia or adenosine deaminase deficiency. Rapid trio exome results identified compound heterozygous variants in SLC52A2. One of these was a known pathogenic variant, and one was a novel variant of uncertain significance, again, in trans. So what does this gene do? It causes something called Brown-Violetta-Van Leer syndrome, type 2, or BVVLS2. So this presents typically with nystagmus and optic atrophy. They can have a sensory neuropathy that leads to gait abnormalities and ataxia. They can have muscle weakness, more notably in the upper extremities as compared to the lower extremities, respiratory insufficiency, hearing loss, tongue fasciculations, and on testing, they can have elevations of a variety of acylcarnitines and organic acids. And this is a progressive disorder with a variable phenotype. So riboflavin is an essential vitamin. I'll show you on a subsequent slide all the different things it's involved in. It's water soluble, and so we do not store significant amounts of this. It's excreted in the urine. The average daily requirement for riboflavin is about 1 milligram per day. Standard nutritional deficiency of riboflavin causes mainly cutaneous abnormalities such as chelosis and xerosis, sore mouth, sore throat, hair loss, and fatigue, but they also can have anemia and vision problems with riboflavin deficiency. There are 3 transporters for riboflavin that are known in humans. The first, SLC52A1, is present in placenta, intestine, and kidney, and this is an autosomal dominant condition. SLC52A2 and A3 are recessive conditions. The SLC52A2 that our patient had, this is expressed pretty ubiquitously, highest in brain and salivary glands, whereas the other is expressed more so in intestines and other organs. So in the process of absorbing riboflavin from the small intestine, the SLC52A3 transporter gets the riboflavin across the brush border of the parietal cells into the parietal cells, and then subsequently SLC52A1 moves riboflavin across the basal level of the parietal intestinal cells into the bloodstream. And then the SLC52A2, again, that our patient has, this is expressed in brain and other tissues and is important in getting riboflavin across the blood-brain barrier and actively transporting riboflavin to neurons and other neuroglial cells. So riboflavin is metabolized into a host of flavin coenzymes shown here, and these are involved in everything from chromatin remodeling to DNA pair, ATP production, antioxidant defense, reactive oxygen species production, and apoptosis. So there are a huge number of things that these flavoenzymes are involved in. Usually, FMN and FAD are non-covalently bound to the different flavoenzymes and catalyze electron transfer. Again, there are hundreds of flavoenzymes involved in all sorts of things, and defects, including notably defects in fatty acid oxidation and electron transport that can lead to biochemical abnormalities that we may see on things like an acylcarnitine profile or urine organic acid analysis. And of these individual flavoenzymes, about 2/3 are already known to cause specific inborn errors of metabolism. So treatment of riboflavin transporter deficiency, in this case that I presented earlier, So the dose that was used was 10 milligrams per kilogram per day. So 10 to 20 times what would be the standard RDA. And you would expect response fairly quickly after initiation of therapy, and this can be monitored biochemically. And again, in our case, what we saw in looking at various biochemical testing, including looking at acylcarnitines, organic acids, and then those things by metabolomics, you can see that we see the impacts of impaired flavoenzyme metabolism in a variety of biochemical pathways, leading to elevated medium chain and certain long chain acylcarnitines, elevations in things like ethyl malonate that's related to the TCA cycle, low levels of arginine, citrulline, and homocitrulline from the urea cycle, abnormalities in tryptophan metabolism, such as formalanthrate and other tryptophan-related metabolites and NAD metabolites, such as kynurenine, kynurenate, and 3-hydroxykynurenine. And then finally, things like elevated neopterin. So in this individual case report, so 3 weeks post-initiation of treatment, the nystagmus had resolved. He had resumed walking, holding onto his parents' hands, and was able to, again, pull up and cruise along furniture. Eating had returned to normal. Parents report that they felt he had a happier disposition, and the reticulocyte count and hemoglobin responded quite dramatically to the initiation of riboflavin, and the neutropenia resolved. Okay, so riboflavin transport disorders may be associated with which phenotype? Cardiac, hematologic, hepatic, or renal? Very good. Sorry. Okay, starting this one with another clinical case. So a 5-day-old with new onset seizures. Seizures responded to pyridoxine, and DNA testing confirmed homozygous variants in the gene that encodes antiquin, supportive of pyridoxine responsive seizures. And this individual started on, and the piperidine 6-carboxylate and piperacillate were tested with elevations in piperacillate that were seen. So therapy for this disorder. So this is a disorder of lysine catabolism, where lysine can be converted either to 2-keto 6-aminocaproate or saccharapine, and then through subsequent steps through piperacillate, or again, saccharapine converted either to piperidine 6-carboxylate or alpha aminoadipic semialdehyde. And you see here the block shown in the blue don't go sign, where this is ultimately converging on the synthesis of alpha aminoadipic acid And so again, in pyridoxine responsive seizures, the cause for the elevation of piperacillate, again, kind of from back up through piperidine 6-carboxylate there. So therapy is with pyridoxine. Typically, it's recommended to start at 100 milligrams per day, but it's recommended not to exceed 300 milligrams per day. The reason is that overtreatment can cause a sensory neuropathy. Now, this is generally seems to be reversible. But again, something you obviously would want to prevent from happening. Some individuals have advocated kind of a lower dose, and then with things that are going to lower your seizure threshold, such as like fever or an infection or other sorts of things, to kind of have a few days of high dose pyridoxine and then go back down to low dose. There's also evidence from some small studies that are cited here on the slide that a lysine restricted diet may be of benefit. And in addition, arginine supplementation, the mechanism here, again, lysine and arginine are both dibasic amino acids, and so compete to use the dibasic amino acid transporter. And so again, that can competitively limit the lysine absorption. So another case presentation, 5-month-old admitted for new seizures and had a hypernatremic dehydration. There were a history of chronic diarrhea. It was thought to be mainly due to amoxicillin treatment. He was irritable and found to have pancytopenia, had elevated total plasma homocysteine of about 73 micromolar. Normal in most labs is under about 12 or 14 micromolar. Vitamin B12 was normal. A bone marrow biopsy was performed that revealed pancytopenia with megaloblastic changes, and he developed respiratory distress. There was a family history of a brother who died at 11 months of age with anemia and respiratory distress in Pakistan, and parents were known to be consanguineous. So results, so the level of vitamin B6 in the plasma was low, and rapid trio exome revealed homozygous SLC46A1 missense variants. So this is consistent with folate transporter deficiency. He was started on leucovorin, and now is 5 years old with no seizures, normal growth, normal development in CSF. So there are kind of two disorders of folate transport. So the first is hereditary folate malabsorption. This is due to impaired intestinal uptake of folate, and the transporter is SLC46A1. This typically presents in the first months of life with megaloblastic anemia, developmental regression, poor growth, low folate in blood and CSF, whereas the cerebral folate deficiency is the FOLR1 gene, and this is the transporter that gets folate from the blood across the blood-brain barrier into the brain. This typically presents usually a little bit later in the first year of life. Again, because the intestinal absorption is normal, you do not have the hematologic features that you have with hereditary folate malabsorption, but you do have the neurologic phenotypes, including ataxia, dyskinesia, and spastic paraplegia. Again, because intestinal absorption is normal in cerebral folate deficiency, you're only going to see low levels of folate in the cerebrospinal fluid, that the blood is going to be normal. As far as treatment goes, with hereditary folate malabsorption, this can be treated with high dose, either enteral or parenteral folate. In this case, one might imagine that since these are missense variants, that maybe with enteral therapy that might be successful, but some people would prefer just to go to parenteral, knowing that the intestinal absorption is going to be significantly impaired. In cerebral folate deficiency, the treatment is with folinic acid, because this can cross the blood-brain barrier without using this FOLR1 transporter. So in summary, riboflavin transport disorders typically present with anemia and pancytopenia, as well as both general and focal neurologic symptoms such as nystagmus and ataxia. Pyridoxine responsive seizures usually seizures are usually well controlled with B6 alone, although there is increasing evidence for a role for lysine restriction and arginine supplementation. And again, avoiding excess dosing of pyridoxine, as this can cause a sensory neuropathy. And then for folate transport disorders, again, there are two of them: hereditary folate malabsorption that presents with both neurologic and hematologic phenotypes and is treated with enteral or parenteral folate. And then cerebral folate deficiency that presents with spasticity and dyskinesia, but does not have any hematologic findings since intestinal absorption of folate is normal, and treatment is with folinic acid, not folate. Okay, so we're going to just kind of have a summary. So this is a little word slide. So people just kind of type in the phenotypes that we discussed with the various neurotransmitter disorders, such as dopa responsive dystonia, GTP cyclohydrolase, aromatic amino acid decarboxylase deficiency, succinate semialdehyde dehydrogenase deficiency. We will hopefully reinforce this all for you as we conclude our talk. Great. So oculogyric crises are a pretty unique phenotype seen with AADC and GTP cyclohydrolase deficiency. We also talked, if someone remembers, with GTP cyclohydrolase, one of the unique phenotypes that's seen with that. So diurnal variation, great fluctuation. Also remember that, again, these are disorders of dopamine and or serotonin biosynthesis. So similar phenotypes to Parkinson disease that we might kind of think of including. So rigidity, I see come up, great. Okay, very good. Okay, so we're going to move on again, kind of the same thing for serine deficiency disorders. So phenotypes that are associated with the different serine deficiency disorders: phosphoglycerate dehydrogenase, phosphoserine phosphatase, and phosphoserine aminotransferase, as well as the serine transporter deficiency. People can kind of type in what phenotypes they recall for the serine disorders. So New-Laxova syndrome, we see, so the severe end of the spectrum with both kind of neurologic phenotypes as well as dysmorphic facial features and various congenital malformations, particularly ichthyosis that's seen with that. Very good. Microcephaly, yes, in the kind of New-Laxova in the early onset forms, developmental delay and seizures. Again, intrauterine growth retardation, good, particularly again in New-Laxova and the more severe end of the spectrum of serine deficiency disorders. See ataxia, very good. Okay, and then moving on to riboflavin deficiency phenotypes. So again, if you recall, there 3 disorders here, 2 of them, 1 autosomal dominant and 2 autosomal recessive, Brown-Violetta-Van Leer syndrome. In the presentations, we see certainly kind of ataxia, right? So again, these flavoenzymes have a lot of important roles. Hearing loss, very good. Nystagmus, hematological, yes, very good. So megaloblastic anemia and neutropenia are seen particularly in Brown-Violetta-Van Leer syndrome type 2, very good. Ataxia, biochemical findings, right? So things like elevated medium chain acylcarnitines, TCA cycle intermediates, very good. Okay, so that's all I have for today. Let's see. Let me just go back to the presentation to be sure that everybody has the QR code here for leaving feedback about the lecture today. Any questions that people have, you're welcome to type them into the chat. Haven't really seen anything in the chat so far. Anybody have any questions?
For hydroxybutyrate, is that a very diagnostic first level marker for SSADH?
Yeah, so that's a good question. So for hydroxybutyrate, we would not usually see that on urine organic acid analysis. So like 3-hydroxybutyrate, beta-hydroxybutyrate, you see all the time in urine organic acids, but certainly 4-hydroxybutyrate is uncommon. So if you do see that, you should be very suspicious of succinate semialdehyde dehydrogenase deficiency. Correct. Other questions? Okay, well, I'm not seeing any in the chat and not hearing any more. People are always welcome to email me if you think of questions, but thanks for your attention and participation, and everybody have a great weekend. And
Thank you, Dr. Sutton.
And should also say that I'm not sure I said it the last time, but thanks to Pete and everybody for putting all this together for everybody. So
Yeah, thank you. Everybody have a great weekend. Thanks again for coming on, Reed. Thank you. Bye.